Our next speakers is going to be Professor Sara Galimberti, who works at the hematology unit at the University of Pisa, Italy. She is the director of the School of Hematology in Pisa. Her lab is one of 4 Italian labs that do all of the MRD testing for the Fondazione Italiana Linformi. I'm going to call it the FIL from now on. So the FIL MRD network has molecularly monitored MRD in several thousands of patients with follicular lymphoma and mantle cell lymphoma. They're also very involved in several Italian networks that perform molecular monitoring of patients with acute myeloid leukemia and chronic neoplasms. Professor Galimberti's lab is also one of 8 laboratories referring to the Euro MRD network that is involved in the Italian harmonization and standardization of MRD in multiple myeloma. So let's welcome Professor Sara Galimberti right now. Thank you.
Welcome to this symposium focused on MRD in hematology. In next 20 minutes, together we'll try to understand what is MRD, why hematologists believe in MRD, and how we can detect MRD in our labs. First of all, what is MRD? MRD is any approach aimed at detecting and possible quantifying residual tumor cells, but beyond the sensitivity level of routine imaging and laboratory techniques. So it means that we can use as imaging tools, for example, positron emission tomography instead of ultrasonography or CT, or the most sensitive laboratory techniques such as next generation flow cytometry or NGS, or ASO PCR, or digital droplet PCR. In hematology today, MRD is really relevant for our clinical practice. In all diseases, acute and chronic myeloid disorders, T lymphomas and acute leukemias, and especially B disorders, such as multimyeloma, non-Hodgkin lymphomas, chronic lymphocytic leukemia, and B acute lymphoblastic leukemia. Unfortunately, today we have not time enough for treating MRD in all these diseases. So we decided to focus our attention to B cell diseases. In multimyeloma, MRD is a real reality in our clinical practice. Indeed, in 2018, it has been performed an international survey, and 70% of clinicians said to use or wanted to use MRD in their clinical practice. After only 1 year, in 2019, the number increased from 70% to 91%. Why? A great number of hematologists today believe in MRD. I think that because MRD is a fundamental endpoint of all treatment projects, because MRD is a sign of a deeper drug efficacy, because MRD is really prognostic, because MRD is now included in all international guidelines, and because MRD is also now fundamental for pharmaceutical companies. After October 2018, when FDA decided that minimal residual disease was fundamental for development of drug and biological products. But I think that for us, for clinicians and hematologists, the most important thing is that MRD is really prognostic across all hematological diseases. You can see here multimyeloma, different studies, different years, different technologies, but the same results. the progression-free survival of MRD negative patients is better than that of MRD positive cases. Either when you use flow cytometry or molecular biology, in this case, ASO-PCR. The same is for CLL. In 2018, the German group published an interesting meta-analysis where they demonstrated that MRD status is fundamental independently on type of regimen used. Indeed, you can see here that MRD negative patient showed a significantly better progression-free survival in comparison of MRD positive patients, either in the FCR arm or in the rituximab bendamustine arm. About ALL, we know that MRD led all therapeutic strategies in pediatric setting, but MRD is now a reality also for adults with ALL. You can see here the new frontier of the treatment of adult ALL patients. The blinatumomab, the bispecific monoclonal antibody, and you can see here that the prognosis of MRD negative patients is really better than that of MRD positive cases. And today, in addition to classical clinical features such as hyperleukocytosis, we consider as at high risk all patients that remain MRD positive during the treatment and that have to go directly to allogenic stem cell transplantation. This is the FOLLOW-5 trial that included more than 800 of follicular lymphoma patients, where our lab, our group, demonstrated that patient with an unsatisfying response, partial response, but MRD negative when we used quantitative PCR for BCL2 JH rearrangement, showed the same progression-free survival of patient in complete hematological response. So MRD status probably is better than the clinical status. So we believe in MRD, but how can we detect MRD in hematology today? I think that we have in front of us three different scenarios: flow cytometry, PCR, and NGS. NGS today is more and more used. You can see the same survey that we mentioned before, and you can see that in 2019, almost half of clinicians decided to use for MRD assessment NGS, in comparison to only 18% of clinicians that use NGS in 2018. Why this success of NGS? I think because NGS has got all characteristics that we want to have when we assess MRD. NGS is specific, NGS is applicable, NGS is sensitive, and NGS today has got acceptable costs. About specificity, in my opinion, we have not really differences between flow cytometry and molecular techniques. If you count different millions of events and you combine different colors, by flow cytometry, you can reach a very, very high specificity. And this is the same by molecular techniques when you use specific molecular markers such as BCL1-JH or BCL2-JH rearrangement, and you add TCR or EGH rearrangement. Also sensitivity. is reachable also by flow cytometry and by molecular biology. We have to reach 10 to minus 4 in the almost all diseases, except for multimyeloma, when we have to reach 10 to minus 5. I think that the superiority of NGS is especially in the applicability rate. Indeed, you have to consider that frequently multimyeloma, mantle cell lymphoma, and CLL are hypermutated. So, ASO-PCR is applicable to only 50–60% of our patients. At the last international meeting on multimyeloma, this Spanish group compared NGS with NGF in more than 200 bone marrow paired samples, with a sensitivity of 10 to minus 5. They clearly demonstrated that we have to combine different frameworks. If we use EGH arrangement, but we use only framework 1, we can apply our method in 83% of our cases. If we use only framework 2 to about 80%, only to 60% when we use only framework 3. When the authors used all these frameworks and added also light chain rearrangement, they had 100% of successes. So this is a reality with the LymphoTrack kit that allows us to combine different frameworks. And when authors correlated NGS with NGF, they found a correlation of 99% with a superiority of NGS. Indeed, 9 out of 13 discordant cases resulted NGS positive, while they were negative by NGF. About non-Hodgkin lymphomas, we know that specific rearrangements such as BCL2-JH for follicular lymphoma and BCL1-JH for mantle cell lymphoma are useful in about half of our patients. So it's better to add or to use the EGH rearrangement that allows to reach a marker for about more than 90% of cases. So probably NGS is better than ASO-PCR, but what about the fight of NGS against NGF? You can see here ALL. This is the curve of patients, the survival of patients that resulted MRD negative both by flow cytometry and by NGS. This in red, the curve of survival of patients that were considered as MRD negative by flow, but resulted MRD positive by NGS. They are not the same curves, so NGS represent an adjunctive value in comparison to flow cytometry alone. The same is in multimyeloma. NGF recovered about 13% of patients that classical flow cytometry defined as MRD negative, and NGS recovered further 30% of cases in comparison to NGF. In CLL, in a cohort of 62 patients, all patients who received FCR were considered as MRD negative by flow cytometry. But when these patients were reassessed by NGS, only 25% resulted really MRD negative. If you translate all these numbers in your clinical practice, perhaps you will misdiagnose about 70% of your patients. So you can drive wrong conclusion and wrong therapeutic strategies. Another hot topic today is the sensitivity of multimyeloma. You can see here the different progression-free survival according to the MRD status tested by flow cytometry with a cutoff of 10 to -4. The curves are really different. But if you use NGS, you can restratify this cohort in 3 different curves. And you can see here that the patient with MRD lower than 10 to -6 have the best progression-free survival. But in the routine, do you think that reach and maintain 10 to -6 would be really possible? Because you have to use more than 20 microgram of DNA for 9 replicates. It means that you have to run 1 sample for cartridge with impossible costs. The situation is really different when we have to reach 10 to -4. We can use less than 1 microgram of DNA, and you can run more than 20 samples for cartridge. This is our experience. You can see here that with only 400 nanograms of DNA, we reached 10 to -4 with a confidence higher than 99%. So we used a small amount of DNA, we used a lymphotrack, and we clearly reached 10 to -4. 10 to -5 for multimyeloma by lymphotrack is possible because you can use 3 replicates of 1 microgram each, so we can run 7 samples for cartridge with acceptable costs. I think that NGS could have also 2 further advantages. The first one is that NGS can be used in different compartments, and the second one is that NGS is an unsupervised tool for assessing MRD. The so-called third compartment, plasma, can be relevant when we use NGS for assessing MRD on cell-free DNA. And you can see here the progression-free survival, different curves, when we use NGS for testing MRD on cell-free DNA. And another interesting target can be exosomes. Exosomes are extracellular vesicles useful for understanding the dissemination of solid cancers, but exosomes are also produced by hematological diseases, such as chronic lymphocytic leukemia, or myeloma, or non-Hodgkin lymphomas. We can hypothesize that exosomes can be the target of our MRD detection, because it's not rare to find a situation when we have patients who are MRD negative in bone marrow, but relapse outside bone marrow, especially in multimyeloma or non-Hodgkin lymphomas. And you can see here that the possibility that the assessment of MRD on exosomes is really possible. This is our experience in a case of CLL. By lymphotrack, we found 2 different clones that were the same that we observed in bone marrow. About the second characteristics, differently, NGS is unsupervised method vision, while ASO-PCR is supervised. I want to show you these cases. A young man with BLL had the diagnosis and post-induction, qualitative and quantitative PCR, detected 1 clone that we'll call the violet clone. already at diagnosis and after induction, NGS show two different clones, the orange clone in addition to the violet one. After the cycle 3, all was good, patient became polyclonal, and after the cycle 7, ASO-PCR for the violet clone was still negative. But NGS show a very small amount of the violet clone, 1.8, and unfortunately, we were not able to define this read as clonal because it was not twice higher than the third most frequent read. So officially the patient was ASO-PCR negative and polyclonal by NGS. But we discussed about this case and we decided to consider him as monoclonal and he received allogeneic stem cell transplantation. Was it good? The patient achieved full chimerism, but during the follow-up, we observed by NGS the reappearance of the a very small orange clone. We discussed about the possibility of performing donor lymphocyte infusion, but we were worried about the risk of chronic GVHD, and so we decided to wait. But it was not good, because after 2 months, patient relapsed with 15% of blast. And you can see here both the clones, the violet and the orange clone. If we use only ASO-PCR, so we can lose one of the 2 clones. In this case, the unsupervised vision realized by NGS were really more productive. And finally, the costs. Usually, we say that NGS is more expensive than PCR. It's probably, but you have to consider the time for ASO-PCR and the time of NGS. If you consider that for ASO-PCR, the time is long and that NGS is an unsupervised method, I think that the costs are the same. And I suppose that the costs are also the same from NGS in respect of NGF, because in NGF you have to combine different many monoclonal antibodies. So NGS is good, NGS probably is better than flow cytometry, NGS is better than ASO-PCR. So I think that NGS is really the new frontier of MRD detection in hematology, because NGS is sensitive, is unsupervised, is prognostic, and is feasible in different contexts, including the plasma. So I hope to having convinced you that NGS is feasible, NGS is not really expensive, and NGS is useful in MRD today. And I would to thank all biologists that every day perform MRD assessment, especially in my lab, Phil and Euro MRD network, and especially in vivo scribe that today allowed us to be here. And finally, but not at least, I would to thank you, all of you, for your kind attention. Thank you very much again.